all note taker. If you'd like to be a panelist, kindly do accept Dr. John Bennett's request. And now we can start with my lecture. Okay. Share. Can you guys see my screen? Can everyone see my screen?
Sorry, is that full screen?
Yes.
Yeah, okay, fine. Go ahead.
Right. Okay. So today we're going to be talking about a little bit about pharmacology.
Excuse me, Mother, could you make the script a little bigger? The text is not too readable. Make it a little bigger. Yeah, that's better. But yeah,
Okay.
excellent,
Fine,
excellent. Very good.
All right. So first of all, anticonvulsants. There are a few drugs that you need to know for like any exam that you want to give, especially for the USMLE. So basically, this table right here is divided into three groups. You have the narrow spectrum, mostly used for focal seizures. You have the narrow spectrum, and then one drug used specifically only for absent seizures. And then we have the broad spectrum, which you can use for both focal and generalized seizures. So, for the first category, we have three drugs. We have phenytoin, carbamazepine, and the gabapentinoids, most commonly gabapentin, as we all know it. So, firstly, with phenytoin, there are a few common adverse effects that a lot of people sometimes tend to forget, but they're always like tested. So the main ones that you want to remember is like a rash, hirsutism, and the drug interactions through CYP 450 inductions. So these two are like the most famous ones, but then you have the other less commonly tested, for example, dizziness, diplopia, sedation, and gingival hypertrophy. There are also some rare side effects which can come up in many exams. So what you want to remember for phenytoin is that it can cause a syndrome called Stevens-Johnson syndrome. It can also cause hepatotoxicity, affecting liver. So it's very dangerous to give in a patient who has renal damage or kidney damage. It can like worsen their condition. It is also teratogenic, meaning you cannot give it to a pregnant woman as there will be a lot of complications. Very simple, straightforward. There is also another drug which has the same mechanism as phenytoin. It blocks the sodium channel. And this drug, carbamazepine, also has the CYP 450 inductions. So this is also like another drug which causes drug interactions. So you have to be careful when you're like administering it. It can also cause a rash, SIADH, and then the other like normal adverse effects, which are like very common: sedation, dizziness, diplopia, vomiting, diarrhea. The rare side effect is also really important that you have to remember that carbamazepine is also teratogenic, so it can cross the placenta and cause a lot of birth defects to the infant. The next drug, gabapentin. Now, this mechanism is slightly different compared to the above two drugs. This drug blocks the calcium channel, and the most common side effect is that it causes weight gain. Gabapentin, like there isn't really like a serious adverse effect that you have to remember for the exam, but just remember that it's a calcium channel blocker. Now, for absent seizures, this always comes up. There's only one drug. It's simple, it's easy to memorize, ethosuximide, which is also a calcium channel blocker. And the adverse effects here: dizziness, vomiting, sedation. Some people try to make mnemonics. I wouldn't really advise making mnemonics because like you can get confused, as ethosuximide is like very similar to gabapentin, but then there's a different side effect. Like, for example, only one causes weight gain, so this can be a little confusing for students. Moving towards the broad spectrum drugs which are used for focal and generalized seizures. So you've got valproate. Now, valproate blocks not only the sodium channel, but also the calcium channels, and it blocks GABA transaminase. So, this is like a drug which has multiple functions. Now, moving towards the adverse effects, again, it has drug interactions, so we have to be really careful when we're administering it in different patients. It can also cause easy bruising, sedation, dizziness, vomiting, weight gain, hair loss, and the most important serious adverse effect that you have to remember is that it is teratogenic and it can cause hepatotoxicity and pancreatitis. Moving towards lamotrigine. This is a sodium channel blocker. It causes Stevens-Johnson syndrome and the normal adverse effects, sedation, dizziness, rash. Next is a special drug called levetiracetam. Now, this blocks the synaptic vesicle protein 2A. Because this is highlighted, you have to remember it. I can't say if this is tested regularly, but it's just something that's good to know for like exams or whatever. This drug also has like the common side effects like sedation, dizziness, fatigue, but now there's a very important serious side effect, which is that it can cause psychosis. So we have to be very careful in administering this drug, especially if the patient has any psychiatric disorders that we don't know about. That's why it's really important to take a complete history, just so we don't make any mistakes from our side. Lastly, we have the drug topiramate, which is a sodium channel blocker, and it's a GABA A receptor potentiator. It has normal adverse effects, the ones that we've all discussed: sedation, dizziness, mood disturbance, weight loss, depression. But the most important side effect that you have to remember is that it can cause kidney stones and ankylosing glaucoma. So from this table, like the adverse effects are all like basically the same, except you just have to remember a few of them. You have to remember gabapentin side effect and the fact that phenytoin, carbamazepine, and valproate. Only these three drugs, they have drug interactions. They're like P450 inducers used in CYP 450 induction. So like this table, many people, what they do is that they try to break it down, like write it a few times or like try to memorize it through mnemonics. Do whatever suits you, but make sure you get your information correct. Like, for example, if someone was to ask you, what's a calcium channel blocker? What does it do? Which one of these is used for absence seizures? Like, it should click to you immediately. Moving forward, okay, next page. Where is it? Okay. Now, we have this famous diagram. Here, basically, you can see the different, all the drugs that we just discussed and exactly where they're located. Sometimes you can get this diagram and be asked to identify which drug is located where. For example, if you look at the top right-hand corner, you'll see the calcium channel blockers, the gabapentinoids, gabapentin, next ethosuximide used for absence seizures, and 3 valproate. If you look on the top left-hand corner, you'll see the sodium channel blockers, and you can see the sodium channel. So the drugs here, phenytoin, carbamazepine, valproate, lamotrigine, and topiramate. At the bottom, you can see the SV2A receptor blocker. This was highlighted, so there's only one drug here. So it's just better to like associate it to this. You can think of a mnemonic too, like RL. That's what I used to like memorize it. Like L stands for the drug, and then receptor blocker SV2A. If you look at the bottom, you'll see the GABA agonists. There are only 3: benzodiazepines, phenobarbital, topiramate. And at the bottom, please don't ignore this drug. This is a GABA transaminase blocker. There's only one, which is valproate. Some people like to draw this diagram out like a couple of times to remember it, while others, they'll just like associate the drugs with like where the channels are located. So anything that like helps you remember, you should stick to your method. All right, moving on to barbiturates and benzodiazepines. So there are many drugs which are barbiturates and benzodiazepines, but there are a few that you need to know. I'm not saying that you should memorize each and every drug in these classifications, but you should know the most famous ones. For example, in barbiturates, we've got phenobarbital, which is like very famous. So basically, this increases the duration of the calcium channel. The only difference between a barbiturate and benzodiazepine is that barbiturates increase the duration of the calcium channel opening, whereas benzodiazepines increases the frequency of calcium channel opening. So there's two words. One drug increases the duration, while the other increases frequency. So they both start with the word B, so think of a good mnemonic. Um, Both are used for anxiety, seizures, insomnia, but benzodiazepines are used for also status epilepticus. There are a few drugs mentioned here, for example, lorazepam, diazepam, midazolam. But benzodiazepines are also used for like other conditions, for example, eclampsia, medically supervised withdrawal of like let's say alcohol, in which diazepam is preferred. They're also used for night terror, sleepwalking, and for insomnia. Um, all right, adverse effects for barbiturates. They cause CNS depression. This is one reason why these drugs are not being used frequently. They're also contraindicated in porphyrias. The overdose treatment is supportive, assisting in respiration and maintains BP. Another important thing is that this causes drug interactions. These are inducers of cytochrome P450. This is why they're very dangerous. Moving towards benzodiazepines. So basically, you have to remember that there are three different categories of benzodiazepines. You have the short acting, which lasts less than 6 hours. You've got the intermediate, which last between, they've got a half life between 6 to 50 hours. And then you've got the long acting ones, which are, their half life is like more than 50 hours. The ones, the one drug which is short acting, I've marked it on my textbook. If you can like see the short small tick, um, there's like three drugs: triazolam, oxazepam, and midazolam. These are short acting. Moving towards the intermediate drugs, we've got clonazepam, lorazepam, and oxazepam. So oxazepam is like some people put it in the section of the short acting, while others they like to think of it as an intermediate acting drug. So that's all right. Moving towards the long acting, there are two, and they're really important. One, which is very famous, I'm sure everyone knows about it, it's diazepam. The other one is chlordiazepoxide. It's a bit long, but just remember the long one. If there's something starting with a C and it's long, it's a long acting one. That's how I remembered it. Benzodiazepines, they have some adverse effects, which you should know. They are very dependent. People like develop dependence on them. They're very addictive too. They cause CNS depression effects with alcohol and barbiturates together. But there is less risk of respiratory depression and coma than with barbiturates. Now, for example, if there's a person who has overdosed on benzodiazepines, thankfully, we have a drug that can help them, that can help overdoses. And it's a famous drug called flumazenil, which is basically a competitive antagonist at GABA benzodiazepine receptors. Can precipitate seizures by causing acute benzodiazepine withdrawal. So, this is like another side effect that you should remember. Moving forward. Okay, let me get this right. Why isn't it moving? Okay. We've got insomnia therapy. So there are three, again, we have a table, and we've got three agents. The first one is a non-benzodiazepine hypnotic, We have a few examples, starting with the letter Z. Well, one of them has like Z in between, but we classified them as like the drugs that start with the letter Z. So you've got zolpidem, zaleplon, and ezopiclone. They act via the BZ1 subtype of the GABA receptor. Now, the adverse effects here, we have the ataxia, headaches, confusion. But the most important thing that you have to remember here is that it caused only modest day after psychomotor depression and few amnestic effects versus the older sedative hypnotics. So even the drugs which are like hypnotics and non-hypnotics, there are a few differences that you have to remember. So these drugs, starting with the letter Z, they put you to sleep. Sleep duration due to rapid metabolism by liver enzyme reverses by liver enzymes. These effects are reversed by, remember, the important drug flumazenil, which we just discussed. The dependency's risk is decreased and sleep cycle disturbance is decreased versus the benzodiazepine hypnotics. So there are two differences. Moving towards the next drug, suvoxirant. So how does this work? It works as an orexin receptor antagonist. The most important adverse effect here is CNS depression. You've got like others. I don't really think it's really important to know like, okay, headache and abnormal sleep related activities. The most important one here is CNS depression. Um, like always, we've got a contraindication. You cannot use this drug in narcolepsy. And this drug has also very strong CYP3 CYP3A4 inhibitors. So we've got to be careful. Also, we cannot use this drug in patients with liver disease. It's not recommended. Um, there's limited risk of dependency. Not a very important thing that you should remember. I think the most important thing to remember is the first two which we just discussed. Moving towards the last drug, which is one of my favorite drugs, ramieltion. This works through the melatonin receptor agonist. It binds MT1 and MT2 in the special nucleus. Now, those of you who attended my previous lecture, we've already been through the table with the different types of nucleus. So this is the suprachiasmatic nucleus. The adverse effect here for this drug is that it causes dizziness, nausea, fatigue, and headache. There aren't any known risks of dependency. So this drug is like easy to administer, easy to discontinue the dose. So, I mean, there's not like huge risks that you need to be worried about. And you can pretty much use it in like different kinds of patients. Moving towards the triptans, the most famous drug here, sumatriptan. How does it work? Now, sumatriptan, it works with a 5-HT, it's a 5-HT agonist. What do? They inhibit the trigeminal nerve activation and prevent a very important component. It's called the vasoactive peptide release. I've actually nicknamed it the VIP just to like help me remember it. Of course, you're free to use your own mnemonic. And the induce vasoconstriction. Now, triptans are mostly used in acute migraines and cluster headache attacks. So here in this textbook, they've got like their own creative mnemonics, like a sumo wrestler trips and falls on their head. Of course, you're free to use your own, whatever helps you memorize the most important information. Triptans, they also have some adverse effects that you need to be aware of. They can cause coronary vasospasm. So that means they're contraindicated in patients who have angina. What type of angina? For example, vasospastic angina. The other adverse effects is that it can cause mild paresthesias and, of course, the famous serotonin syndrome. Moving towards Parkinson's disease therapy. Where did it go? Okay. The most effective treatments are the non-ergot dopamine agonists, which are usually started in younger patients, and levodopa with carbidopa is usually started in older patients. Deep brain stimulation of the SDN or GPI may be useful in advanced disease. So, for Parkinson's disease, we've got a few strategies that can help patients according to their needs, according to the age, and according to patients' conditions. For example, let's discuss the first one, the dopamine agonists. The most preferred agent are the non-ergot. For example, Pramex, pramipexole. I always mistake this drug. So this drug includes nausea, impulse control disorder, postural hypotension, hallucinations. There's another drug, the ergot ones, which is bromocriptine, but this is rarely used. Most important reason, because of its toxicity. Moving towards the second strategy, which is basically to increase dopamine availability. There's a drug here which we use. It's called amantadine. This increases dopamine release and decreases dopamine reuptake. Please don't get confused and try to think of this. Try to associate it with the arrows. So if you've got an arrow going up, it's increasing dopamine release. And you've got an arrow going down, that's decreasing dopamine reuptake. And this is mainly used to reduce levodopa-induced dyskinesias. Now, this drug also has an adverse effect, which is basically toxicity. Through its toxicity, it can cause peripheral edema, livedo reticularis, and ataxia. So there's three important things that you need to know. I think this is high yield, so it's best if you can think of a mnemonic or just learn it as it is. The third strategy is to increase L-DOPA availability. Now here, agents preferred are the peripheral agents. So you've got levodopa and carbidopa. Carbidopa blocks the peripheral conversion of L-DOPA to dopamine by inhibiting an enzyme, the dopa decarboxylase. Also reduces adverse effects of peripheral L-DOPA conversion into dopamine. For example, reduces nausea, reduces vomiting. So patients who are suffering with nausea and vomiting, if they're suffering with peripheral symptoms, you can use this strategy to help decrease their suffering. We've got another two drugs, entacapone and talcapone, which prevent peripheral L-DOPA degradation. And they are also used in combination with levodopa. Next strategy is preventing dopamine breakdown. Now, there are a few agents which act peripherally, which we just discussed, and then there are others which act centrally. So they are post-blood-brain barrier. They cross the blood-brain barrier to inhibit breakdown of dopamine. We've got a drug called selegiline. This blocks conversion of dopamine into dopa-C by selectively inhibiting monoamine oxidase B. Now, please remember this. It's not monoamine oxidase A, it's monoamine oxidase B, which is more commonly found in the brain than in the periphery. We've got another drug, which we just discussed in increasing dopa availability. It's also mentioned here, talcapone. This crosses the blood-brain barrier and blocks conversion of dopamine to 3-MT in the brain by inhibiting central COMT. Lastly, but not leastly, curb excess cholinergic activity. We've got a drug here. We've got a couple, two drugs here. We've got benztropine, trihexyphenidyl. So trihexyphenidyl, it's antimuscarinic, which means it improves tremors, rigidity, but it has little effect on bradykinesia in Parkinson's disease. Now here they've made their own mnemonic, as usual. Try parking my Mercedes-Benz. It's catchy. I don't know how helpful it is, but again, you're free to think of your own mnemonic. We've got a little diagram here. So basically, some people like reading just tables and, they can understand information and, they can just apply it when they're taking their exams. While others, they like visualizing because you see, learning is different. There are different types of learning. We have visual learners. We've got people who write and then are able to recall. So if you're like my brother who likes visualizing diagrams, then you've got an amazing diagram here, basically highlighting everything that we discussed but in like bullet points and something which is like concise. Me, however, I like reading tables and like repeating them, trying to like think of a mnemonic to relate them together. So both of them are available, and of course, it depends from student to student and different strategies you can learn just to like understand the entire topic. All right, now we're gonna talk a bit more about carbidopa and levodopa because the previous page we've just discussed the different strategies. Now here, with both these drugs, they increase dopamine in brain. Unlike dopamine, L-dopa can cross the blood-brain barrier and is converted by the dopa decarboxylase in the CNS to dopamine. Carbidopa is a peripheral dopa decarboxylase inhibitor that cannot cross the blood-brain barrier. So here is an important difference. Both are used in Parkinson's disease, and they both have some adverse effects. Three that you have to remember: nausea, hallucinations, and postural hypotension. We've also got this one phenomena. It's basically called the on-off phenomena, which is like patients, they have improved mobility during on periods, but then they've got impaired motor functions during off periods. So like you have this phenomena that you have to like be careful in observing a patient's prognosis when you're administering both these drugs. Moving towards a neurodegenerative disease therapy. So we've got three diseases here, and we're just trying to like compare them through agents, mechanisms, and like some important notes. I really like this table because it's like the three most important drugs that always come up, and it's like written in one place, and you can just take the information in and try to understand it. So the first drug here is Alzheimer's disease. And basically, you've got two agents. First one, donepezil, rivastigmine, and galantamine. How do they work? They're basically acetylcholinesterase inhibitors. These are used as first line treatment for Alzheimer's disease. Of course, they've got the adverse effects too: nausea, dizziness, and insomnia. These drugs are contraindicated in patients with cardiac conduction abnormalities. The next drug, which is used for moderate to advanced dementia, that's memantine. Please do not mind my underlined things. I've just like made my own notes, underlining something or circling something just to help myself. Of course, you're free to like have your own methods of memorizing or recalling. So memantine, sorry, is an NMDA receptor antagonist. The reason why I've circled N is for me to remember that it's an NMDA receptor antagonist. You might call it clever. All right, moving on. This helps prevent excitotoxicity, which is mediated by the famous component calcium. And the adverse effects here are dizziness, confusions, and hallucinations. Moving towards the next disease, we've got amyotrophic lateral sclerosis. There's another name for this, and it's called Lou Gehrig's disease. I'm not sure how many people know that, but it's always good to know different names of a disease. It just helps with your knowledge. The agent here, which is used, is a drug called riluzole, and this works by decreasing glutamate excitotoxicity. This increases the survival in patients who have this disease. Now, moving towards the last disease, which is Huntington's disease. We've got two drugs here: benazine, and deutetrabenazine. They inhibit VMAT, which basically decreases dopamine vesicle packaging and release. They can also be used in Huntington's chorea and tardive dyskinesia. So basically, you've got some important notes here, the mechanisms of some drugs which are used in these important diseases. Moving towards local anesthetics. So you've got two groups, very simple, very straightforward. You've got the esters and the amides. The esters, for example, cocaine, tetracocaine, and the amides, um, always have two I's in their name. Now, this is like a cheat code that you can use to like help yourself remember which category drugs belong to. For example, lidocaine, two I's meaning it's an amide. Similarly with pilococaine, prilococaine, two I's, it's an amide. How do they work? Well, they block neurotransmission by binding to sodium channels, and they're most effective in rapidly firing neurons. They can be given with vasoconstriction, usually epinephrine, to block duration of actions by decreasing systemic absorption. The order of loss first is pain, second, temperature, third, touch, fourth is pressure. They're clinically used in minor surgical procedures and spinal anesthesia. If you have a patient who is allergic to an ester, you can give an amide. The adverse effects here, most famous ones, for bupivacaine, you have the severe cardiovascular toxicity. For cocaine, you've got arrhythmias, and for benzococaine or prilococaine, you've got methemoglobinemia. So these adverse effects of these four drugs are very important to remember. They do come up. Moving towards some general information about general anesthetics. There are CNS drugs. So CNS drugs, they must be lipid soluble because we have to cross the blood-brain barrier, right? Drugs which decrease the solubility in blood, they have rapid induction and recovery times. However, drugs which increase the solubility in lipids, for example, isoflurane, they increase potency. So if something's solubility is increasing, potency is also similarly directly proportional. That means it also increases. Now you've got something that we can measure, which is basically something called MAC, which stands for minimum alveolar concentration. We use this to measure inhaled anesthetics. Um, what is this basically? Like, why are we using MAC? It's basically required to prevent 50% of the subjects from moving in response to stimulants. For example, we have an equation here. Potency equals 1 divided by MAC. Basically, we can say potency is inversely proportional to MAC. The higher the potency, the lower the MAC. That's just something that you can use to help yourself understand. We've got a few mechanisms here of the few drugs, and we've got their adverse effects. You don't have to memorize all of them. I'm just going to read the ones which are most important. Basically, you've got like two groups here, the inhaled anesthetics and then the IV anesthetics. The inhaled ones, the most important one that you should remember is that isoflurane, it can cause malignant hyperthermia. And moving towards the intravenous anesthetics, you've got propofol, etomidate, and ketamine. Now, with ketamine, this inhibits NMDA receptor. So it increases BP, increases heart rate, increases cerebral blood flow, and increases ICP. But it causes hallucinations and vivid dreaming. Um, Going above ketamine, you've got etomidate, which is it potentiates GABA A receptor, and it can cause acute adrenal insufficiency. Also, it can cause postoperative nausea and vomiting. Next, propofol. Now, propofol has two functions. It is also an NMDA receptor inhibitor, but it is also a GABA A receptor potentiator. Now, what does this drug do? It decreases BP. One thing I want you to remember is that even though it's an NMDA receptor, just like ketamine, this drug, this anesthetic decreases BP, whereas with ketamine, we have an increase in BP. Propofol is the most commonly used IV agent for induction of anesthesia. Something else that you can remember for exams, as it's like really common to use. Moving forward. to the neuromuscular blocking drugs. Now, here we've got two categories. You've got the depolarizing neuromuscular blocking agents, and you've got the non-depolarizing neuromuscular blocking drugs. So for the depolarizing ones, we've got succinylcholine. Here, I want you to remember the two phases of blockage. Phase 1, which is prolonged depolarization, there's no antidote. Phase 2 is repolarized but blocked. Nicotinic receptors are available but desensitized. So you can clearly see that there are two main differences. Complications here include hypercalcemia, hyperkalemia, and malignant hyperthermia. So, like a mnemonic that you can use is that everything is increased. Calcium increased, meaning hypercalcemia. Potassium increased, hyperkalemia. And temperature increasing, malignant hyperthermia. This also increases the risk of prolonged muscle paralysis in patients with pseudocholinesterase deficiency. Another important thing that you should remember when taking histories is checking to see if the patient has any allergies or if the patient has any deficiencies, just so when you're administering certain drugs, you can easily identify which drug we can give to a patient and which drug we shouldn't give to a patient and what are the adverse effects. Moving towards the non-depolarizing neuromuscular blocking drugs, we have the drugs which have like CUR in them. It's like highlighted. You've got Vicoronium, Atracurium. So these are all nicotinic receptor antagonists. Now here, anticholinergics are given with cholinesterase inhibitors to prevent muscarinic effects, for example, bradycardia. Not much to remember with the non-depolarizing neuromuscular blocking drugs, but it's just good to know like what happens and what you can give in adjunct therapy. So, we've already mentioned the word malignant hyperthermia like almost twice. What is it? It's basically a rare, life-threatening hypermetabolic condition caused by the administration of potent inhaled anesthetics. For example, isoflurane or succinylcholine. Now, here, calcium is increased. Calcium release is increased from the sarcoplasmic reticulum. The most important receptor here that you have to remember is the ryanodine receptors. What happens is that calcium increases, the muscle contractions are sustained, and as a result, you've got hypercapnia, tachycardia, increase in heart rate, you've got muscle rigidity, you've got hyperthermia, increasing in body temperature, and you've got rhabdomyolysis. Good thing is, we've got a treatment. We've got a drug that can help with malignant hyperthermia. The famous drug, dantrolene, which is a ryanodine receptor antagonist. So, two drugs which we can use in like problems. Let's say I've got a patient who has taken benzodiazepines, an overdose. We've got flumazenil. Let's say a patient who has malignant hyperthermia. There's a drug, dantrolene. So medicine is not really that complicated. We've got a few drugs which are basic antidotes, so it's always good to remember them. Today, this is what we've discussed. Hopefully, in the next series, I'll be talking more about the pharmacology. We've got a few more things that we can cover. This will be for next time. If you do have any questions, you can ask now, or you can always like email me or text me later. Thank you, everyone.
Okay, thank you very much. Okay, yeah, anybody, you can just type in, text in your question to the, excuse me, to the chat. If you don't want to speak, just let me know. Oh, someone did ask, let me review here. She asked, what book did you use, I guess?
Okay, so
Yeah,
basically,
what book are you using? Yeah.
this book is a USMLE Step 1. It's the
Can you show,
2020.
can you screen share, please, an image of the
Uh,
book?
sure. I don't think I've got a picture of it, but I can always show you which.
Amazon does probably, right?
Yes. Yes, I'll just like have a quick Google search. I'll show you which one I've used.
That's a beautiful building in Russia.
Yes. Thank you.
What's the name of that? It's famous. I know it's famous.
The one in my background or like
Yeah,
the one which I
yeah.
was Googling? Oh, this
You-
is in Sochi. I
no,
took
the
a
one
picture.
with like a castle, a red castle,
Yes, that's the Red Square in Moscow.
red square. Beautiful.
Yes.
Okay, I've seen it all my life, didn't know what it was. Okay, yeah, just that's the book you took it from. That's for Zoo, I believe.
Yes. So basically, this book comes in like different editions. You don't have to waste your money and get like the latest edition. It's just a fancy name. But what you can do is like download like previous editions, for example, 2023, 2022, whatever you find. I would suggest not to download something like really old, let's say 2019, like that's too old. Syllabus also like updates. So it's basically this one. USMLE Step 1, First Aid. I'm sure there are many downloads available and it's free too. So this is the textbook I was using.
Yeah, I have a
Yeah.
comment, Mila. In my day, they had a lot of repeat questions from the prior year, something like 25% or something. So students, Kaplan, a preparatory company, used to send students in just to take the test, to memorize the questions, to come outside. They built up the bank of questions that were previously used. And it was a good way to prepare because if
Yeah.
it didn't have the exact wording, it had more or less the thought in there
Yes.
that they could change the wording a little bit, but the essence of the question was still inside. So that was a very effective. Is that advised also for the students to take questions from
Um,
previous years?
yes, people
Yeah.
do. For example, if there's a group of friends or like let's say people in college who are taking the exam together, let's say like 20, 30 people, they're always, free to like sit down together and, like jot down the questions that everyone knows. And at the end, you can have like a few papers to give to like juniors. That's also advisable too.
Funny question, Mila. Well, funny
Yeah.
comment, actually. In my test, the
Mm-hmm.
student next to me had a seizure during the test because
Oh,
obviously it's a high stress situation, da 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 da. And there we are, a room full of doctors to be. No one did a thing. Everyone just watched him seize
that's
and got
scary.
back to the test after he stopped. I was
So
next to him
scary.
too. I feel guilty too. I didn't do something, but there is nothing. He just rested a minute and started the test again. Didn't
Wow.
want to miss the opportunity to finish that test.
I
Okay,
completely relate.
okay. Anything scheduled for next week? Do you have any idea?
Not yet, but I will
Okay.
like let you know what I can plan, hopefully.
Yeah, we'll see how it goes. Perhaps if it goes well, we can increase the frequency.
Yep.
We'll see how it goes. Okay. Okay. Thank you,
No,
Mina. Have a great day.
no problem. Thank you, Dr. John.
Okay. Bye-bye.
Bye-bye.
Please stop here. We'll stop recording and stop Zoom. Yeah. Let me just tell you something. Hold on.